Hello.
Okay. Excellent. Elizabeth, I'm Mark Cotton. I'm the moderator, or if you can just take us through the highlights of your poster, please.
Sure. Good morning, good afternoon, and good evening, everyone. On behalf of my colleagues in the Division of Global HIV and TB at the Centers for Disease Control and Prevention, I'm honored to be presenting our poster at this conference today. So thank you to all of the organizers. According to Neonates estimates, only 54% of children living with HIV globally are on antiretroviral treatment, compared with 62% of adults living with HIV. The two maps in the center demonstrate the differences within countries that persist despite global initiatives focused on these gaps. The same scale is used for the map on the left, which shows percent of children on treatment, and the map on the right, which shows adults on treatment. And the darker green corresponds to a higher percent on treatment based on Neonates estimates. A cursory review shows that across the 17 highlighted countries, a smaller percent of children are on treatment. However, we can use robust modeling approaches to improve our assessment of temporal trends in children on treatment relative to adults, allowing us to dig deeper into this data. Would you like me to speak louder? Is the audio okay?
There was a bit of interference, but it seems much better now.
Okay.
So just carry on.
All right. To do this, we use PEPFAR quarterly data for the current treatment of children and adults living with HIV from October 2016 to September 2019 in 17 countries where PEPFAR supports direct HIV service delivery with age disaggregated data. We fit two generalized linear models for time series data for the pediatric population, meaning less than 15 years, and the adult population, meaning 15 years or greater. The first model, on the far right of the top, estimated the annual percent change in number of sites providing treatment. The second model on the bottom estimated the annual percent change in people living with HIV on treatment, adjusted for the number of sites. Statistically significant differences between a country's pediatric and adult population were conservatively shown with non-overlapping 95% confidence intervals. For both models, all results reflect annual percent changes, with children in red and adults in blue. In the first model, showing percent change and number of sites providing HIV services, all countries increased the number of sites providing services to children, with the percent change ranging from 1% to 21%, with a median of 9%. The annual growth in sites serving children outpaced that of adults in 3 countries, Zambia, Cameroon, and Namibia, by a statistically significant difference. In the second model, when adjusting for the number of sites, only half of countries demonstrated positive annual growth in children on treatment between 2016 and 2019. The countries are in the same order as the first model for ease of comparison. And we see that 4 countries, DRC, Mozambique, South Sudan, and Zambia, exceeded 10% annual growth for children, whereas there were 11 countries that exceeded that much growth in adults. 3 countries, DRC, Mozambique, and Zimbabwe, demonstrated annual growth in children on treatment that exceeded that for adults. Despite the larger pediatric treatment gap, children overall had less growth in number of people on treatment compared to adults. Now, this analysis is subject to some limitations, including differences in burden of HIV among children and adults, variations in timing of HIV policies and initiatives, changes in treatment delivery strategies within the countries, and data inconsistencies. But in conclusion, despite the expansion of pediatric treatment services to more sites, only half of countries consistently increase the number of children on treatment during these years. Decentralization of pediatric treatment services may be insufficient by itself to capture children not yet on treatment, with factors such as case identification and retention playing a large role. Our results emphasize the need for more focused, data-driven efforts to expand HIV treatment for children living with HIV. Thank you.
Thank you very much. I've got a question, and do you think that decline in transmission rates might explain some of the drop in numbers or the lack of expansion for children?
That's a great question, and I heard it somewhat discussed even earlier today that we would expect aging out to be occurring so that there would be fewer children who would be eligible to be on treatment. But despite that, we still have a large treatment gap. We know that we still need to find, identify, and start many children on treatment. And so though I do believe that children are aging out, part of the problem is we're not finding all of the children that are infected.
Yes. Do you get any data on extra efforts made to find children? That some of the countries that are doing well may be doing something extra?
Yes. We tried looking at some things from a macro perspective, looking a little bit at characteristics shown by Neonates, and we tried looking a little bit at some of the policies that are engaged in some places. And we do see that some countries do have more active case identification initiatives. But since this poster is a little bit on a large scale, it will take a little more research to dive down in deep to see why countries seem to have more growth than others.
Okay, no, thank you. I'm looking in the chat box if there are any other comments. I can't see any. Any other last messages you would like to make for this poster, Elizabeth?
I'm sorry, can you repeat that?
Any last point you want to make?
No, I only find that this poster in this this modeling study is very much in line with some of the earlier sessions that were discussed today about the need for more identification and case identification in children.
I agree, and thank you very much for highlighting this, and carry on the good work. Thank you very much.
Thank you. Have a good day. Thank you for the opportunity.
Thank you. And if we could have the next poster, it's model-informed prediction of Dollytegra PK in neonates. Another important topic, and the speaker is Hardik, Chandasana.
Hi.
Hardik, over to you.
Are you able to hear me okay?
I can hear you very well.
Yeah, thank you. Thank you for giving me this opportunity. Hi, I'm Hardik, and I'm a member of Clinical Pharmacology Modeling and Simulation Group at GSK. And on behalf of my co-authors from GlaxoSmithKline and Viv Healthcare, I'm presenting this poster. So DTG, as we know, they recently approved in the USA for the pediatric subjects of greater than 4 weeks of the life and greater than 3 kg of the weight. And it has a potential for treatment of HIV infection as well as prophylaxis in the neonates. It's very critical to use DTG in the neonate population, but starting with the selection of the optimal dose and prediction of pharmacokinetics in neonates is very, very tricky and challenging because of rapid development changes occurring in neonatal organ systems. So what was our objective? Our objective was to predict PK and select starting dose for the upcoming clinical trial of DTG in neonates. For this one, what we did is we used mathematical modeling and simulation to predict the pharmacokinetics in neonates. So the population PK model developed using pediatric exposure data from Impact P1093 and Penta ODC used for this simulations. Full model and the talk was given by Rajendra Singh earlier. That was the poster number 2. So that same model we used for the prediction of the PK in the neonates. So as I mentioned, to study DTG PK in neonates, GSK has developed one of the liquid formulation. So in this work, the absorption characteristics from the liquid formulation and recently approved disposable tablets were considered similar. What we did, we simulate a number of clinical trials virtually with a different dosing scenario in neonate population with aim to achieve target C trough, as mentioned by Rajendra Singh, greater than 697 nanogram per ml. That was our target. So 3 different dosing scenarios were simulated using liquid formulations such as 0.5 mg per kg, 1 mg per kg, and 1.5 mg per kg. And 4th one was done using the 5 mg disposable tablet formulation. As you can see from the right-hand side from the table number 1, the 0.5 mg per kg dose after birth has a low likelihood to achieve target CTRA of above 697 nanogram per ml concentration. But going into the neonate, which is a very tricky scenario, and so we are going to start with the very conservative starting dose, because we don't know how the UGT1A1 enzyme maturation process work, because there are a lot of uncertainty and variability in UGT1 maturation process. So the starting dose what we are going to select is we selected is a 0.5 mg per kg. In conclusion, I would like to say that this type of mathematical model-based simulation approach can effectively use to derive starting dose for the neonate in a clinical trial with the PK and safety data available with this 0.5 mg per kg dose will subsequently use to derive chronic dosing regimen in the neonate using mathematical modeling and simulation. Thank you for your attention.
Thank you very much. Can I ask if you, and I might have missed this, do you consider the mother's ALRT, whether she's on Dollytegra as well? How does that influence your dosing?
Yes, that could influence the dosing as well. But in this poster, we have considered assuming no prior exposure to DTG. So we simulated this one for exclusive for DTG naive subjects. We also did simulation, or we also did some study where if mother is exposed to DTG, so when we should start giving dose into neonate as well. But that I'm not including here. So I'm just limiting this one to the neonate which does not have a prior exposure to DTG.
Thanks. And are premature and low birth weight infants on your agenda to consider?
Not this point in time. This one is mainly a mature baby greater than 2 kg of the weight. So once we'll study in this kind of population, then we'll have a better idea to study into the immature babies.
Do you have any concern about the UGT pathway and hyperbilirubinemia?
Yes, that's the reason we are starting with the very low dose, 0.5 mg per kg, because there is uncertainty. And if you see, we are unable to, with our modeling and simulation, it says that our target will be below to that, but we don't know about uncertainty. That's what we are starting with 0.5 mg per kg.
Yes, no, thank you very much. And what formulation?
So currently we are going to start with as I mentioned, we do have a liquid formulation as well that is specifically developed for this population, to study in this population.
Yes, no, thank you very much. Again, I'm looking for any other comments. I can't see any, and if anyone on the panel that I can see has a question. Thank you very much, and good luck with your work. We look forward to a neonatal dose of Dollytegra. Thank you very much.
Thank you very much.
Thank you. If we could have our next poster, please. Oh, yes. And the speaker is... let me just see...
Hello, good afternoon.
Yes.
It's me, my name.
Sorry, I got a bit... yes, it's
no problem.
Rozenszajn.
Rozenszajn, yes. Mijael, yeah, right.
Mijael, oh, great. So welcome, and please tell us about your complex work.
Thank you very much. Thank you, the organizing committee, for this opportunity. The present work is a collaborative work between Garahan Pediatric Hospital from Buenos Aires, Argentina, and Baylor College of Medicine from Houston, Texas. And in previous studies of our group in the hospital, we found that the major resistant pathway to raltegravir, the Q148H, was impaired in individuals carrying BF recombinants with the subtype F integrase gene. And the epidemic of HIV in Argentina is characterized by a high proportion of recombinant form, with the BF recombinants being the main CRF type. And also it was important because raltegravir is currently the preferred first-line regimen for HIV-infected neonates, and also as a rescue regimen for those children failing to the first-line regimen. If we could zoom in the upper area, the gray and the brownish box, please. And also, it was very important to characterize thank you very much, to characterize the resistant pathway selection in our population, because there's a thought that the Q148H pathway could produce some level of resistance to second generation integrase inhibitors like dolutegravir and bictegravir. And also because dolutegravir is yet to be approved for the use in pediatric, so we were very interested about this. So we raised two questions. Can integrase subtype affect treatment outcome to a raltegravir-based regimen in children from Argentina? And also, what is the impact of such resistance mutation and HIV subtype on replicative capacity? And we believe it's worth mentioning that the majority of drug-resistant studies worldwide are conducted on subtype B, while in many countries, also low to middle income countries, subtype B are the least frequent subtype, and many other subtypes are frequent. So we took two approaches. If we could move to the right of the poster, please. Two different approaches, thank you very much. We analyzed treatment outcome in our cohort of children receiving raltegravir regimen as a rescue regimen. And we analyzed the timing to virological suppression, and then those who achieve virological suppression, the timing to virological failure. And in those who had virological failure, we also analyzed which one of them selected for mutation or those biological failure were associated with selection of mutation that were absent from the baseline. Our colleagues of Baylor College of Medicine, they performed some in vitro characterization of the viral phenotype through site-directed mutagenesis and analyzed the replicative capacity and drug susceptibility. Now, if we can move to the lower left corner of the poster, a little bit higher. There you go. Thank you. Well, as you can see in the gray box, in the gray table, we have the general characteristic of the cohort. We did not find any difference between the median age of raltegravir initiation nor the median viral load at raltegravir initiation nor the time on raltegravir regimen. Also, as you can see in figure 1, no difference between the proportion of patients achieving virological suppression or virological failure between subtypes. And when we come across the RAM-associated virological failure, we did find some difference, although not reaching statistical significance. And if we see the figure 2, where we see Kaplan-Meier analysis, and table 2, I believe, if we can go a little bit lower of the poster to see the table 2 also, you will see that as you see, figure 2A, 2C, and 2E are the survival analysis of those endpoints. No statistical significance is shown in 2A and 2C, and also in 2E, where we only analyze patients whose virological failure was associated to a selection of mutations. But as you can see in table 2, the p-value for the difference between the median time of subtypes to each endpoint is starting to show a trend towards statistical significance. I have to be honest with you, but with the pandemic, many of our work had to stop because we work in the hospital, and the virology unit where I perform my research had to go full time on COVID-19 diagnosis. So we had many sequences to be sequenced and also analyzed, and we believe that if we could repeat the analysis with more sequences, we will see a statistical significance between subtype B and subtype F timing to virological failure when we see those patients whose virological failure is associated with mutation selection. And then for the in vitro characterization, if we can move to the lower right corner of the poster, please. Thank you very much. It was performed with 3 molecular clones, NL43 as a subtype B virus, URTR23 as a characteristic subtype F integrase with the G163K polymorphism, and also ARMA159, and also classical subtype F recombinant circulating from Argentina. Those infectious molecular clones as wild type show no difference in the IC50 concentration for raltegravir and dolutegravir. As many literature predicts, the introduction of N155H induces raltegravir resistance, but not dolutegravir, and this was independent of the subtype because we see very similar results between subtype B and subtype F, and also independent of the G163 polymorphism that is also believed to be a secondary mutation to integrase inhibitors that potentiates the resistance introduced by primary mutations. And then the Q148H pathway was analyzed. The introduction to the NL43 backbone as subtype B showed the expected result with little or no change in replicative capacity and quite a high resistance level for raltegravir and an interesting level of resistance to dolutegravir. And the big question and the big finding of this is that when we introduce the Q148H mutation to both subtype F integrase gene, those viruses had little or no capacity of replication. So we started to review some literature, and we started to think that maybe the fact that codon usage was the sole explanation for a subtype constraint mutation selection, maybe it was not the whole picture, that maybe the Q148H, as we can see in the results, has such a big impact on the replicative capacity of those viruses that it could never be selected or it could never be present so that the secondary mutation that rescued this classical mutation fitness, the G140S, could ever emerge. So in a bigger way, we hypothesized that maybe those patients carrying BF recombinants of Argentina, carrying an integrase of subtype F, could be free of cross resistance, yes, between raltegravir and dolutegravir, since the subtype F could never select for the Q148H resistance. Of course, we still have some results to be analyzed. We are following another cohort of pediatric patients that failed to raltegravir with the selection of Q148H, of course, of subtype B. And we wish to see what is the effect of the dolutegravir therapy on them. And also of subtype F patients that failed to dolutegravir, of course, without the Q148, but with the N155H. That will go under dolutegravir to see what is the impact of those present mutation at baseline of dolutegravir in the outcome of dolutegravir treatment.
Thank you. So these were all children who were on Dollytegra?
No, these all were children with raltegravir.
Raltegravir, and yeah. Okay. So what is, in summary, what is going to happen with Dollytegra now when it's introduced?
Well, we believe that there will be a difference between subtype B patients, actually subtype B integrases, patients carrying subtype B integrases or subtype F integrases, since subtype F, as we can see from both literature and in vitro experiments, is not able to select the major resistant pathway to dolutegravir. But we yet have no information about if there will be another resistant pathway that may emerge specifically for subtype F. Because as we all know, the mutations that are listed especially for Dollytegra or many other new antiretrovirals, may differ between in vitro experiments and what we see in the clinical setting. There's no always a good correlation between them. So we expect to see if there is any difference in the mutations resistance that are selected for subtype F than for subtype B, specifically if there is a new one yet to be described in the case of subtype F.
Have you seen any other subtype differences for any other of the antiretrovirals?
No, as I can remember from the discussion in our lab, in our group of study, we did not see any difference between subtypes concerning treatment outcomes to any other ARV regimens or families. There was some difference that was seen in a genomic level, but not on the clinical level, concerning PIs and some GAG mutations that were also subtype constrained, but I believe they did not have any impact on the clinical outcome. So there's also, it's quite challenging because it's not enough to see a difference on the genomic level. We also have to confirm it that it has an impact on the clinical level, because maybe it's just another mutation, another difference that the HIV as a quite diverse virus can generate, but it may not implicate any in the clinical setting.
Thank you very much. It's very intriguing, and we will look forward to your delineating more information about this interesting pattern. Thank you very much.
Thank you so much for the opportunity.
No, thank you. And I haven't seen any other questions that have come through, but I'm sure people can contact you. And
yes,
so,
of course.
Yes. Thank you.
I'd be pleased to share some question with anyone that has them.
Excellent. Thank you. And let's go to our next poster. It's Ariana Traub and expanded index testing and community-based testing in Nigeria.
Hi there. Can you hear me?
Yes.
Perfect. Hi, everyone. So my name is Ariana Traub, and today I'll be presenting our analysis on the effectiveness of expanded index testing and community-based testing modalities in Nigeria on identifying children living with HIV on behalf of our team from USAID, as well as RISE, which is a PEPFAR USAID central funded project. While prevention of mother-to-child transmission programs have been scaled up globally, there still remains a large number of undiagnosed children living with HIV or CLHIV in CLHIV. Nigeria has a high rate of new HIV infections and around 134,000 undiagnosed CLHIV. Beginning in around April of 2019, index testing, both in the facility as well as the community, as well as other community-based modalities, began being scaled up in Nigeria. This study assessed the change in pediatric case identification when these index and community-based testing modalities were scaled up. We used USAID PEPFAR data from 4 states in Nigeria, including Adamawa, Akwa Ibom, Cross River, and Niger, and compared the changes from fiscal year 19 quarter 1 to fiscal year 20 quarter 2, or October 1st, 2018 to March 31st, 2020. And we define children as being less than 15 years old. So the figure in the third panel looks at both the overall volume of tests and the volume of positive CLHIV who are identified across all modalities, facility-based modalities, community-based modalities, as well as index testing modalities, both in the facility and the community. Overall, we saw that the volume of tests increased from fiscal year 19 quarter 1 to fiscal year 20 quarter 2 by about 25%. And additionally, the percentage of positive tests, or the positivity, which can be seen in the purple boxes, increased from 10% to 18%, with an additional 248 CLHIV identified in fiscal year 20 quarter 2 compared to fiscal year 19 quarter 1. Both index and community-based modalities began being scaled up in fiscal year 19 quarter 3, with resultant increases in both in overall positivity as well as the overall volume of CLHIV that were identified. 498 more children were tested through these index testing modalities in fiscal year 20 quarter 2 compared to in fiscal year 19 quarter 1, which resulted in an overall positivity increase of 5%. Overall, the volume of tests, the volume of CL-HIV who are identified, as well as the positivity increased from October 2018 to March 2020, when these community and index testing modalities increased. Therefore, our recommendations are to scale up these community and index testing modalities in high-burden HIV settings, such as Nigeria, where children may not be coming into the clinic if they're asymptomatic.
Thank you very much. Could you tell us a bit more about the index testing? It clearly was something that was introduced and wasn't there at the beginning, and just about the history of it and how it's going and how one communicates this message.
Definitely, yeah. So index testing, particularly for children, is you use an HIV positive individual. And so for children, a lot of times this will be their mother is HIV positive or an HIV positive sibling in order to identify contacts. And so with an HIV positive mother, you'll want to test all of their biological children to see if you can identify other children who may be living with HIV who weren't identified during the PMTCT cascade or through EID. And this has been particularly scaled up over the past couple years, 2 years, and really with an emphasis in this fiscal year to be scaled up substantially to identify the remaining children living with HIV.
Yes, no, thank you very much. And in the future, is this going to be rolled out even more? What do you think?
So, right. So that's the hope, is that while we're entering into this current fiscal year, that index testing should be scaled up across all of the PEPFAR countries that we're currently working in, and using this index testing to really identify children, again, those older children that were discussed in an earlier presentation today that were missed in EID and missed in PMTCT, and we're finding a lot later and a lot older ages, and to be able to identify them. And so the hope is that index testing will be scaled up as we move along. And so I believe that particularly in countries where we're really still seeing a high prevalence of children living with HIV who are undiagnosed, I think that index testing is going to be an excellent way to identify those children by going back to their positive mothers who are HIV positive and who have not identified their children as being HIV positive.
Thank you very much. I think we have to move on now. That was a very good data.
Thank you very much.
Thank you. If we can have the next one, it's Mukendi. It's from South Africa, and it's on early infant diagnosis.
Everyone, can you all hear me properly?
Yes, we can hear you.
Okay. My name is Aurelie, and on behalf of the Center for HIV and STIs, I will be presenting our poster evaluating the performance of the gene expert. In South Africa, the implementation of the PMTCT guidelines has allowed for significant improvements in maternal and infant health outcomes. However, as the prevalence of pediatric HIV has dropped, the positive predictive value of diagnostic tests used for EID has also fallen. And a key part of our study was in describing the diagnostic accuracy of a point-of-care test such as the gene expert. In regards to our methods, we analyzed data obtained from a longitudinal cohort of HIV-exposed infants who had HIV PCR testing performed at birth. The study was conducted at 4 tertiary sites in the Gauteng region of South Africa, and all infants that had a detected HIV screening test, as well as concurrent testing performed on the gene expert, were included in this evaluation. The performance of the gene expert in predicting the final HIV status was determined as proportions with 95% confidence intervals. We also compared a small subset of indeterminate results that were obtained on the CAP-CTM with discordant results on the gene expert. In our study, from a potential sample size of 172 infants, we had 150 infants that met the inclusion criteria. Of these 150 infants, 6 had an expert test result that was discordant with the final result on the CAP-CTM. 5 infants had false negatives, and 1 infant produced a false positive HIV test result. As a consecutive assay, we found that the expert had a sensitivity of 96.5%, a specificity of 85.7%, and the positive predictive value of 99.3%. The negative predictive value of the expert was 54.5%, and we had an overall accuracy of 96.1%. In Figure 2, we proposed a new EID algorithm where discordant results between the CAP-CTM and the gene expert were used as criteria to verify indeterminate results. In this study, we had 18 infants with an indeterminate HIV result. By applying the algorithm in Figure 2, the number of indeterminate screening results would have been reduced by 42.1%, from 18 infants who had an indeterminate result to 11, without increasing the false positive rate. In conclusion, on account of the excellent positive predictive value that the gene expert showed, as well as the accuracy, we concluded that the addition of the expert as a consecutive test for specimens with an HIV-detected PCR screening has the potential to alleviate the decline in the positive predictive value and also help in reducing the indeterminate rate in South Africa. This can also help in reducing the diagnostic challenges faced, as well as the time to final status within the South African EID program.
Thank you very much. Is there a difference in cost for the two?
Yes, with the expert in the study, we found that it was much cheaper, and the total runtime was 90 minutes, which is shorter than currently what happens within the NHLS, where a lot of patients are lost to follow-up as well, which causes hospitals to incur further costs when it comes to tracing up the patients and infants.
Yes, for sure. And why do you think that the expert is performing better under these circumstances, and can we use it for both?
Definitely. I would say with the experts, one of the things that made it very popular with the staff was that it was very easy to use. So the fact that it was easy to use meant that if there were any results that were discordant or any errors, they could be repeated while the patient was still in the hospital. And an advantage of using the expert is in South Africa, they are already using it for TB testing. So they have quite a large footprint in South Africa, which means that the government wouldn't have to worry about any further costs in terms of procurement for the instrument.
Yes. Thank you very much. I think that concludes our session. It's been a very diverse and interesting poster session, and thank you very much to all of the presenters for really interesting, very different work. All are really advances in our approach to HIV and really doing the best we can to treat, eliminate, and to diagnose. Thank you very much, everyone, and enjoy the rest of the virtual meeting.
Thank you, Mark.
Okay.
Thank you for the opportunity.
Bye, everybody.
Thank you very much.
Thank you.
Bye-bye.